Hello, everyone that's joining. We're just going to give a few seconds here to let attendees come in. I see the numbers ticking up and for our YouTube folks, so we're just going to give a few more seconds here for people to get on. All right, well, I am going to get started with our introductions today. Hello, everyone. My name is Hannah Mortensen, and I am the Executive Director of Physicians for Social Responsibility Wisconsin and the Wisconsin Environmental Health Network, also called WEHN or WEN. And our group is a group of health advocates and health professionals that are concerned about how our environmental toxins and climate change affect our health and the public health. We are advocates and we like to provide as much educational knowledge as we can. So this series is part of that effort. So again, thank you to all that are joining tonight. And I'm going to pass it over to our intern, Marina Steiner, who's going to go over some of the housekeeping for tonight.
Hello, everyone. Welcome again. Tonight with the presentation, just a couple things to expect. Only the panelists are visible and can speak tonight. So you only see these 4 videos. But if you want to submit a question, which you can do at any time during the presentation, we'll address them at the end of the presentation, do our best to get to all of them based off of the time that we have. But to ask a question, you can go to the bottom of your Zoom screen. There's a Q&A box where you can submit your questions during any time of the presentation. If you might be joining us through YouTube or on your phone, you're free to submit a question via email at our email there, wehnmail@gmail.com. And then if you want to change the view of your presentation tonight, on the right side, there's a view icon where you can change where the videos are of the presenters, as well if you want to change how the presentation looks. You can also change that in view options at the top when the screen is shared, if you want the presentation to be bigger or smaller, depending on your computer size. Right now, I'll hand it over to Claire, who will introduce tonight's speaker.
Hi, I'm Claire Gervais, and I'm pleased to introduce Dr. Christine Till. She's currently an associate professor of psychology at York University in Toronto. She's a clinical neuropsychologist and adjunct scientist to the neurosciences and mental health program at Sick Kids Hospital in Toronto. She's the 2019 recipient of the President's Emerging Research Leadership Award and the principal investigator on an NIH-funded study focusing on the effects of fluoride exposure during pregnancy on child neurodevelopment. So tonight, she's going to speak with us on the scientific evidence of the neurotoxicity in early fluoride exposure. And we're so pleased to have her. So without further ado, we'll switch to Christine Till.
And I will get set up a moment. Okay, thank you everyone for the invitation and the lovely introduction. It really is an honor to speak with this group about fluoride and the developing brain. I know this is a topic of emerging interest in Wisconsin, so it's my pleasure to talk about this research and have some time at the end for questions. So when it comes to the safety of fluoride, the history is fascinating. It truly provides the background for how the safety of fluoridation was first established and then maintained over the past 75 years. So let's go back to this 1955 Scientific American article that begins with, many people, particularly scientists, believe that we are suffering in the US from a national epidemic of irrationality, what Senator J.W. Fulbright has called the swinish blight of anti-intellectualism. So this article was referring to the thousands of citizens in communities across the US who who became embroiled in heated battles over whether fluoride should be added to their public water supply. Some felt that the benefits were greatly overstated, with potential risks not well known. Experts contended that no other public health measure has ever been so thoroughly studied and tested before it was introduced. The article goes on to note how fluoridation of public water supplies is endorsed by an impressive list of scientific organizations, including the American Dental Association, American Medical Association, and the US Public Health Service. Here's a picture of some public health officials from New York State celebrating the endorsement of community water fluoridation as a safe and effective way to prevent cavities. So here's a simple timeline that highlights some relevant events that have taken place over the past 75 years. I'll start with 1945, but I should note that the initial discovery of fluoride prior to this time is also quite fascinating. But in the mid-40s, we see the first trials begin in Grand Rapids, Michigan, as well as some areas in New York and Brantford, Ontario. Trials were supposed to last 10 years, but by about 1950, the US Public Health Service endorsed fluoridation. And by 1960, we have community water fluoridation to over 50 million people in the US. And around this time, fluoridated toothpaste is also introduced and marketed widely. So by 1990, we begin to see a rise in the number of studies examining health effects of fluoride. Of course, there were studies prior to this time as well, but you really start to see more and more happening in the 90s. By 2006, the National Research Council reviews the health effects of fluoride, and I'll talk about this document in a moment. And in 2015, the US Public Health Service recommends 0.7 milligrams per liter as the optimal level for community water fluoridation, which is the same as we have in Canada. And it wasn't until 2017 to 2019 when we saw our first 3 prospective birth cohort studies published. And then in this past year, we have the National Toxicology Program release a systematic review. And also in the last year, we've had a landmark fluoride trial against the US EPA, which started in June 2020 in a San Francisco federal court and will resume next month. So when talking about fluoride, it is important to distinguish between topical and systemic sources. Topical sources include dental products such as toothpaste, mouth rinses, and fluoride gels, where fluoride is found in very high concentrations. The anti-caries effect of these fluorides is well proven, and of course, the fluoride from these sources is not meant to be ingested. Systemic sources of fluoride include some food types like grapes, in which fluoridated fungicides and insecticides are commonly used, as well as beverages that are made with fluoridated water. Of course, fluoridated water is the main source, as well as tea. Tea in particular has been identified to have high concentrations of natural fluoride, which it gets from the soil it is grown in. Other sources include pharmaceuticals, including halogenated anesthetics like sevoflurane, as well as fluoride supplements. This figure shows the proportion of fluoride intake from various sources like water, food, and beverages, toothpaste, and so on. The lavender bars shown here, and then the yellow beverages, shows that the main source of fluoride intake comes from the water and beverages that we consume, accounting for over 80% of total intake in people older than 14. Now, ingestion of fluoride from toothpaste, which is shown in green, is not very common in older individuals who are likely spitting out the toothpaste, but it does represent an important source of exposure in young children. In fact, analysis of the 2013-2016 data found that over 38% of children aged 3 to 6 years use more toothpaste than recommended. So at this age, it is recommended that young children use about a pea-sized amount of toothpaste, but it was found that they're using more than this. In Canada and the US, the optimal concentration of fluoride is currently set at 0.7 milligrams per liter to protect against tooth decay. This compares against the much lower level of naturally occurring fluoride, which is found in most fresh water of about 0.05. There can be higher levels depending on certain geographic areas and the types of rock in that area. The maximum level depends on whether you're in Canada or the US. Currently in Canada, it's 1.5 milligrams per liter, and in the US, the maximum contaminant level is set at 4 milligrams per liter. This map shows the percentage of the population receiving fluoridated water. And globally speaking, you can see that North America is an area where fluoridation is common, where we add fluoride to drinking water. In Canada and the US, it's also found in Brazil, Australia, New Zealand. And you can see that most of Europe does not add fluoride to drinking water, except for Ireland. About 39% of individuals on public water supplies in Canada receive fluoridated water, compared to about 73% of the US population. In Mexico, salt is fluoridated instead of water, though water supplies can also have varying degrees of naturally occurring fluoride. Now, the Centers for Disease Control and Prevention hail water fluoridation as one of the top 10 public health achievements in the 20th century. So let's look at what the data show in terms of the efficacy of this intervention. This is a Cochrane review that was published in 2015. So Cochrane researchers are an independent group of scientists who review systematically the empirical evidence that meets a high bar of quality to inform decision-making. And overall, the main findings showed that in children, there is a 26% reduction in decayed, missing, and filled permanent teeth. And that translates to about a difference of 1.2. So there is a benefit for young children. In adults, there is insufficient evidence. This Cochrane review also concluded that there is very little contemporary evidence that has evaluated the effectiveness of community water fluoridation for the prevention of caries. The majority of the studies, about 71%, were conducted prior to 1975 and were characterized as having a high risk of bias. What that means is that most of the studies that were included in this Cochrane review failed to account for individual fluoride intakes, other important factors like sugar intake, socioeconomic variables, for example. And I should also mention that because we're looking at studies that were conducted prior to 1975, this means that most of the studies were done at a time when fluoridated toothpaste was coming on the market, rather than today when current lifestyles and other preventative measures are commonly used. So looking at data from a more recent study, this was done by Slade et al. In 2018. They compared the preventive benefit of fluoridation among people, young children living in areas that were predominantly fluoridated compared to non-fluoridated, and they did find a benefit of about 1.3, whereas in the permanent teeth, the benefit was much smaller at 0.3. Now, looking over time, these 6 nations that have adopted fluoridation show that dental health does seem to be improving. But you can also look at the countries that did not add fluoride to drinking water and see very similar trends in this decline in tooth decay over time, suggesting that there might be other factors that are contributing to the decline in tooth decay that is not related to fluoride, perhaps reflecting changes in oral health behavior, improvements in diet, changes in lead exposure, for example, or use of fluoridated toothpaste. So when I started this research, I, like most people, I heard that many research studies have proven the safety and benefits of fluoride. That is the first sentence on the CDC website. And when I went looking for this research, and looking for the support for these many research studies, I found that there were actually very few human studies examining the health effects of early life exposure to fluoride at levels that are within the range of water fluoridation. What about the support for safety? Of the studies conducted to date, they did not all conclude that exposure to fluoride is harmless. So let's go back to 2006. This is when the evidence for adverse health effects of fluoride were reviewed by the National Research Council. So a committee of scientists reviewed all of the available research in terms of these outcomes that are listed here. The committee reported concerns related to dental fluorosis, bone fractures, and skeletofluorosis that were related to a lifetime exposure to fluoride at drinking concentrations of 4 milligrams per liter. Now, the report also gave some credibility to the possibility that fluoride exposure may be associated with other health outcomes in humans that are shown here in gray, but they did not have as much evidence to support this relationship. So they ended up saying that future study was necessary, looking at these other outcomes, especially for vulnerable populations. And one of the NRC panel members, Dr. Isaacson, was quoted as saying, "This report should be a wake-up call." So we'll fast forward now 15 years, because now we have quite a few more studies that allow for a more thorough review of the evidence for developmental neurotoxicity of fluoride. The National Toxicology Program identified over 500 references that were relevant to this topic or to thyroid-related health effects. So they have 159 human studies that they reviewed, quite a few animal studies and some in vitro studies. It's worth noting that there are far more studies on fluoride neurotoxicity compared to other chemicals like PFOA or air pollution that have been assessed by the National Toxicology Program. Now, this heat map shows the studies that the National Toxicology Program assessed. They assessed each study, which are listed here at the top, and they gave them a score for several domains that are listed here along the vertical axis. So of the 159 human studies that they evaluated, 31 were deemed to be of high quality, or in NTP terms, low risk of bias. So the dark green or light green would represent a study that has a low risk of bias for that particular domain, where yellow would be a probable high risk of bias. Most of the studies that were included as low risk of bias were done in children. So 20, all but 2 were done in children. And based on the systematic review of the evidence, the NTP concluded that fluoride is presumed to be a cognitive neurodevelopmental hazard to humans. This conclusion was based on a consistent pattern of findings in human studies across several different populations. However, the conclusion is somewhat nuanced. They also noted that the consistency is based primarily on higher levels of fluoride exposure, i.e. greater than 1.5 parts per million in drinking water. So in other words, the studies with exposures falling below 1.5 ppm, so like the optimal level, exposure level, were deemed to be inconsistent and therefore unclear, whereas at higher levels, the risk was presumed. So let's return to those 29 high quality studies that were done predominantly in children. The 29 were done in children. And the first thing you can see, so on the bottom here is the direction of the effect. The first observation is that none of the studies showed a benefit in terms of neurobehavioral outcome, but most of them, all but 2, found an adverse effect. Then we can subdivide the effects by levels of exposure. So the studies that are shown here in blue arrows or purple arrows were done in communities where the water fluoride levels were less than 1.5 milligrams per liter, where the black arrows represent studies that were conducted in areas with higher levels of fluoride, such as endemic fluorosis areas in some parts of the world. Now, the NTP report also included several meta-analyses. These were mean effect meta-analyses, meaning they compared the studies that grouped an exposure group compared to a control group. And when they looked at these studies in this manner, and you can look at the overall effect, this is the overall difference between the exposure group and the control group, they found a standardized mean difference of about negative 0.5, so that's about half a standard deviation. And what's remarkable is that this value is quite consistent with 2 prior meta-analyses that were conducted in 2012 and 2018, which was roughly half a standard deviation as well. And then we can dig down and do some more subgroup analyses where we only look at the studies that had low risk of bias, so the higher quality studies, and you can see that the effect remains significant. The other types of meta-analyses were also conducted where they compared the overall effect for the studies that measured exposure on a continuous variable. So for example, urinary fluoride. So you have some people with low and some people with higher levels. This includes our study of maternal urinary fluoride, lumped with the other studies that looked at urinary fluoride in the entire population. And again, they found an overall effect showing a decrement in IQ with higher exposure. So a year ago, my team and I published this paper in JAMA Pediatrics. This study was based on the MIREC sample, which recruited 601 mother-child pairs from 6 cities across Canada. Half of the cities were fluoridated, as shown by the red stars, and half of them were in non-fluoridated communities. The mean urinary fluoride levels were about 2 times higher among pregnant women living in fluoridated versus non-fluoridated communities. And between 2008 and 2011, the MIREC program recruited women from the 10 different cities. They were recruited during pregnancy, and at which time urine samples were collected at each trimester of pregnancy. And then the children were followed between ages 3 and 4, and they were tested on IQ using a standardized IQ test called the WIPC. We used 3 measures of fluoride exposure. The first is maternal urinary fluoride, sometimes referred to it as MUF, and we corrected for urinary dilution using both specific gravity as well as creatinine. We also measured water fluoride concentration and derived an estimate of fluoride intake. This was based on questionnaire data that the mother completed in trimesters 2 and 3, asking about her consumption of water, tea, and coffee. Water fluoride concentration was determined for women who reported that they drank tap water. We excluded any women who said they exclusively drink bottled water. We then took the postal codes for each woman, matched it with the zone that each water treatment plant services, and then took the average water fluoride concentration matched in time for the woman's pregnancy to derive a woman's individual water fluoride concentration. The beauty of working with the MIREC data set is there are a number of covariates that we could consider in our model. We considered all of the variables that are shown on the slide, but the ones that were retained in the model are shown in red. Our results showed a large, statistically significant effect for boys. The average IQ loss was about 4.5 IQ points for each 1 milligram per liter increase in MUF, maternal urinary fluoride. Using water fluoride as our predictor, we found an average IQ loss of about 5 IQ points. This was in both boys and girls for every 1 milligram per liter increase in water fluoride. With respect to daily fluoride intake, we found an average of about 3.7 IQ point loss for both boys and girls for each 1 milligram per day increase in mother's fluoride ingestion. We also ran a number of sensitivity analyses that also controlled for other neurotoxicants like lead, mercury, arsenic, and you can see the beta coefficient remained relatively stable. So we did not see a change in the results. They did not change appreciably by controlling for these other factors. So to summarize, a 1 unit increase in fluoride exposure was associated with an IQ decrement ranging from about 3 to 5 points, controlling for covariates. So a lot of people ask, well, what are the implications of 1 milligram per liter? Is that high? If you were a woman living in a fluoridated region, 1 milligram per liter in MUF represents a woman at the 86th percentile. So that means that about 14% of pregnant Canadian women have a urinary fluoride level of 1 milligram per liter or higher. So it's not very high. After much deliberation, we concluded that these findings indicate the possible need to reduce fluoride intake during pregnancy. This conclusion was based on the consistency of our findings, the strength of the effect, as well as the consistency of our findings with the general literature. The paper was published along with an editorial, as well as an editor's note that preemptively defended the journal's decision to publish the paper, as well as a podcast with 2 GEM editors. I think these 2 excerpts from the editors nicely captures the shock and the disbelief. So Dr. Christakis was on the podcast who said, so when I first saw this title, my initial inclination was, what the hell? Dr. Rivera said, the effect size is really quite large. The results are really startling. And indeed, upon its release, the paper was condemned not only by the scientific community, but also by the media. And this is a sample headline from the National Post, our national paper in Canada. And it really does summarize the type of reaction that we received to our work and that the editors had anticipated. Andre Picard, a leading health journalist in our other national paper, the Globe and Mail, wrote, the children of mothers who consumed fluoridated water had slightly lower IQs, about 2 to 3 points based on median fluoride intake of 0.7 milligrams per liter. That is utterly meaningless. IQ is at best an imperfect measure of intelligence. Test results can vary from day to day. Heck, you'd probably lose 2 IQ points watching a Seth Rogen movie. So you see here how critics are attacking the methodology of the study and discounting the significance of the results. Reactions to the paper were international. Here's an example of a billboard that went up in New Zealand outside the airport. The billboard read, fluoridated water lowers kids' IQs, but the implications that lurked from this headline called for immediate action to remove the billboard. The next day, the billboard was taken down because of complaints that the billboard did not give a full picture of what was being claimed. Several months after our paper was published, CADIF, which is the Canadian Agency for Drugs and Technologies in Health, came out with this critical review of our paper. And this is an agency, it's a non-for-profit agency that's responsible for providing Canada's healthcare decision makers with objective evidence to help make informed decisions to improve quality of healthcare services. So when we looked at, well, what were the critiques that CADIF came up with, here are some examples. They said there was no random assignment of the exposure. Of course, that would be quite unethical to randomly assign a pregnant woman and dose one group and say, we're going to follow up your child's IQ and then not dose the other woman. Clearly, this is an observational study. They also said that there was no control for father's education, socioeconomic status, or breastfeeding, which was simply incorrect. And they stated that there were only 369 out of 601 mother-child pairs that were used in their study, which was also incorrect. They concluded that the findings, those are just a sample of some of the critiques. The findings, they concluded, provide weak evidence and should be interpreted carefully, given the multiple aforementioned limitations. Now, we tried to correct the errors in the report. We contacted CADIF. It is an anonymous report. We could not find out who wrote the report. But when we tried to correct the report, we had about 3 pages of comments and corrections. We were pointed to this disclaimer that CADIF is not responsible for any errors, omissions, and so on arising from or relating to the use of the information in this report. And as a result of these critiques and errors that are found in this report, this has contributed to the perpetuation of misinformation. Here is a tweet just from last month where it said, the graph relies on a false study that has been discredited by CADIF. They were referring to our study. CADIF reviewed that study and concluded that conclusion is not supported by its data, fake science. So you can see how errors get picked up as fact, when in fact, they are wrong. Experts continue to conclude that fluoride is unequivocally safe. Here's a quote from the chair of the Oral Health Committee from the American Academy of Pediatrics. There are thousands of articles pointing to the safety of community water fluoridation, and so on. Critics said it is only one study, despite 3 other well-conducted studies over the past 5 years, all of which linked fluoride exposure in pregnancy with adverse neurodevelopmental effects in offspring. So the first mother-offspring study was conducted in Mexico on 65 mother-infant pairs. And this was the first study that noted an adverse association between fluoride in pregnancy and infant mental development index on the Bailey. One thing you might notice is that the range of urinary fluoride is quite high because this represented a group living in an area with quite high exposures to fluoride in the drinking water. So the shaded area here in purple represents the fluoride levels that we found in the Canadian cohort. And one thing that you note is that the steepness of the curve is greatest in this low exposure range. The second study was also conducted in Mexico, but in this population, the women were living in an area with optimal fluoridation. In Mexico, remember, they add fluoride to salt. And what this study found, it was in the element cohort, they found that there was a loss of about 5 to 6 IQ points for each 1 milligram per liter increase in mother's urinary fluoride. And just comparing the MIREC study in Canada with the Mexico study, you see that women who lived in fluoridated communities have very similar levels of urinary fluoride compared to the element study. And comparing the size of the effect was also quite similar. We found a 4.5 IQ point drop, but only in males, where the element study found a drop of 5 IQ points in both boys and girls. So we've concluded that fetal development is a critical period of concern for neurotoxicity. This was based on the 3 high-quality prospective birth cohort studies, all of which reported adverse effects, versus no studies presented or that have been done showing no effect. What about postnatal exposure? We did another study looking at exposure in formula-fed babies. We know that exclusive breastfeeding for 6 months occurs in roughly 1/3 of Canadians and about 1/4 of Americans. So therefore, about 70 to 75% of infants receive formula in the first 6 months of life. Now, this figure shows that infants' dietary intake is quite low if they are breastfed. Breastfed is the green bar, or if they're given formula made with non-fluoridated water. So they're well below this tolerable upper intake level. Now, if formula is made using fluoridated water, you can see, at least within the first 6 months of life, the total intake based on body weight exceeds that tolerable upper intake level. Formula-fed infants living in fluoridated areas have an approximately 70-fold higher fluoride intake than exclusively breastfed infants. I should note that breast milk contains extremely low concentrations of fluoride because of limited transfer from the plasma into the breast milk. Now, what we do know about formula feeding with fluoridated water is that it is associated with an increased risk of enamel fluorosis. And this is a systematic review and meta-analysis that was conducted in 2009, showing increased risk of fluorosis among the formula-fed babies that used fluoridated water. So we asked the question, are formula-fed infants at risk of lower IQ if the formula is made with fluoridated water? And we divided the group into a breastfed group or a formula-fed group. It worked out to almost equal numbers. The breastfed group consisted of mothers who reported exclusive breastfeeding for at least 6 months. So we had 198 mother infants in that group, and 200 children who were given formula in the first 6 months of life. So the design kind of looks like this. We have some infants who are breastfed living in fluoridated communities and others living in non-fluoridated communities, but we don't expect to see an association with water fluoride concentration because these are the breastfed infants, so they're not getting any fluoride. In contrast, the formula-fed babies differ in terms of their water fluoride concentration depending on what type of city they live in. So the formula-fed children living in fluoridated cities like Toronto and Ottawa would have a higher infant dietary intake of fluoride than the infants who live in non-fluoridated communities like, say, Vancouver. And that difference is about 0.5 milligrams per liter. So that's what we used to derive our estimate What we found was this association with higher levels of water fluoride concentration did predict lower IQ in the formula-fed babies. The drop was about 4.4 points. It was significant, but we did not see a significant association in the breastfed group. So we concluded that infancy is a critical period of concern for neurotoxicity. And I should also add that that association remained even after we controlled for prenatal exposure. So if you go to look for what are the current recommendations, should I use fluoridated tap water to mix infant formula? On the CDC website, you will see that it says, yes, you can use fluoridated water for preparing infant formula. However, if your child is only consuming infant formula mixed with fluoridated water, there might be an increased chance for mild dental fluorosis. So to lessen this chance, parents can use low fluoride bottled water some of the time to mix infant formula. And then they go on to say what type of bottled water you might want to purchase. So you can see it's a kind of a circular recommendation. Might be hard for a sleep-deprived mother to wrap her head around. Can I use this type of water or not? And a similar recommendation is made by the ADA. So a big question is, well, are there any benefits of using fluoridated tap water to mix infant formula? And the answer is no. Fluoride's predominant beneficial effect is post-tooth eruption. Yet, about 93% of caregivers who feed formula to infants use tap water. You can't boil this out. If you have fluoride in your water, it's not boiled out. And you can still buy nursery water with the optimal level of added fluoride. So mothers or parents are still being marketed that they can give their infant a fluoridated nursery water, even though there is really no benefit. So in the absence of any dental benefit from fluoride consumption in the first 6 months, we say that it is prudent to limit use of fluoridated water for infants. We also recently did a study comparing across critical windows of exposure because we've measured now fluoride in each trimester of pregnancy. We measured it in infancy, and we also measured it in child urinary fluoride. And I'm going to focus here on performance IQ because the effects were strongest in the nonverbal IQ. What we found was that for boys, maternal urinary fluoride was most strongly associated in boys. So that prenatal exposure had the greatest effect in boys, but in girls, the exposure in infancy appeared to be the greatest period of sensitivity. What was interesting about this finding is if you look at the study by Mullenix from the 1995 rat study, this group also found that male rats were most sensitive in the late prenatal period, whereas female rats were most sensitive in the postnatal period. And we recently published this review looking at sex-specific findings in relationship to fluoride at different windows. Overall, there's a lot of low quality studies. So the conclusions are, I think we still need to research this area, but we did review this and found some evidence that males may be more susceptible, but we definitely need more research examining sex-specific effects in both animal studies and humans. So are there other potential adverse neurodevelopmental outcomes of fluoride exposure? I've been involved in some other studies that looked at ADHD as an outcome, and this was the very first study that I published with Ashley Mallon in 2015. This was published in Environmental Health, and it was an ecologic study, so not very high in terms of the quality compared to the birth cohort study. But what we found was quite intriguing that the states in the US that had a higher water fluoride prevalence were associated or had also a higher prevalence of ADHD. This was after controlling for median household income. So, and this relationship held across the 3 years that we looked at this outcome. A second study was conducted by the Element Group using the biomarker of maternal urinary fluoride. And in this study, we found that higher levels of urinary fluoride was associated with higher parental ratings of ADHD-like behaviors on the Conners rating scale. And finally, in another cohort, this was a Canadian Health Measures Survey, a Canadian Stats Canada data set, we found, and here they measured tap water fluoride like from the home, and we found that an association between water fluoride and the water was associated with a rise in prevalence of physician-diagnosed ADHD from 5.5 to 14%. So for each 0.5 milligram per liter increase in tap water fluoride, there was this associated increase in ADHD prevalence. So what are the implications of fluoride neurotoxicity? Well, if we look at a population curve, in the US, there is about 6 million children falling in the gifted range, and another 6 million children falling in the challenged range. If we shift this population curve down by 5 IQ points, we would only have 2.4 million children falling in the gifted range, and that many more children in the challenged range. So the impact of reducing or shifting the curve downward is staggering at a population level. So I wanted to end with some thoughts about why we continue to hear statements like, there are thousands of studies pointing to the safety of community water fluoridation when there's considerable evidence to the contrary. This quote by psychologist Daniel Kahneman on confirmation bias says, when people believe a conclusion is true, they are also very likely to believe arguments that appear to support it, even when these arguments are unsound. So confirmation bias is this tendency to search for, to interpret, to favor, and even to recall information in a way that confirms or supports one's prior beliefs or one's values. And when it comes to fluoride research, or fluoride in general, confirmation bias is rampant. I would go so far to say that it is found on both sides and among individuals who even know a lot about this topic. Scientists are not immune to this bias either. We can easily spot fatal flaws in studies that disagree with our beliefs, or a study that supports one's position, we might overlook a flaw or consider it trivial. So this has made me think a lot about how do we go about doing research that builds in protections against bias? Because when you go into fluoride research, knowing that there will be people motivated to discredit your research, and they will diligently search for flaws and weaknesses, even if they are irrational or hostile. And this was the expectation, and everyone who reviewed our work, I think from the very beginning when we applied for funding, then when we had to apply to access the biospecimens from the Merrick Biobank, we got like weeks and weeks of more reviews to address, because the reviewers knew that if you're going to do this type of research, everyone anticipated the scrutiny, and the science would have to represent the best methodology possible. And it's the scrutiny what inspired us to take extra care in designing our research to build in protections against bias. What this means is that we were careful to use the best biomarker. So for example, originally I was going to measure urinary fluoride in one trimester, but because of the budget, we were able to stretch the money so that we could get all three urines, all 3 trimesters measured. So like 6,000 urine specimens, we had to measure every single one. Sending them from Canada to Indiana was not easy, but we made it work. We made sure we adjusted for creatinine, for specific gravity. We had to make sure we had the best biomarker. We had to use reliable outcomes. We built a team that included people who thought differently than we did, so they could detect any blind spots. We listened to people who thought differently or who had opposing views. This forced us to think. It also forced us to frame the study so that both a null finding and an effect would be valuable. After all, that was the conclusion going into this research, was it doesn't really matter what the data show. We'll have some data to say that we looked at this important question. So when we say that it is safe for everyone, we can at least say we did a study looking at this. So I firmly believe that if we're going to do fluoride research, it must adhere to the highest standards of methodologic rigor, or don't bother doing it. So now we have the National Toxicology Program, who has systematically reviewed all the research. This is the most comprehensive document on this topic than ever before. And to provide a persuasive document, you need to consider the entire field. So just looking at our studies, definitely not enough. We need to look at all of the available science. And this takes a team of scientists with the required expertise, the required training, as well as screening for conflicts of interest. You must ensure neutrality in this field. And these scientists must wade through every single study, judge it carefully, regardless of whether it supports a position or not. So that was their duty, to sift through the studies and critique them. And if they were poor quality, we really can't use those studies to draw conclusions. They must be the most rigorous studies. So we have now this trustworthy and comprehensive repository of all the science on this topic, put together by a very qualified group of scientists who have presented the data in a non-adversarial manner with the paramount goal of accuracy. And based on the consistency of the studies, they conclude that the evidence appears to show consistent indications of an association between exposure to high fluoride concentrations and cognitive deficits in children. But okay, so that's their conclusion, but now we have this extra level of quality control by the National Academy of Science. So this is another esteemed independent group of scientists who reviewed the process that the NTP took to come up with this conclusion. And they know this is a controversial area. This document must be able to withstand scrutiny. So the National Academy of Science reviewed the process and identified some inconsistencies in their process and their scrutiny of each study. There were some inconsistencies. So they know, just like we know, for our study to be accepted, to be published, in order for anything to be widely accepted, the analysis must be clear and transparent. So right now, we're at the stage where the National Academy of Science has provided very comprehensive feedback to the National Toxicology Program about their process. And in order for this document to hold more weight, to be persuasive, they must present its analysis more clearly and transparently. So I completely agree that this is a fine document, a fine repository. It's my go-to document when it comes to looking at the literature. You can go online and see how they evaluated every domain of every single study. You can click on it and get all the details. It's a fantastic repository for this particular field. But it's going to take a little bit more to get every single agreement on how they rated every single study. But do I think their conclusion will change? No, I don't. The overall evidence is quite consistent. But in order for everyone to buy in, this means that they have to be transparent. And this is really our experience as well, to get our research published. It meant addressing hundreds and hundreds of critiques, showing that we considered the data sets in many different ways. We posted additional analyses on OSF when people asked for additional analyses. You have to be transparent to show we've looked at it, we've done it many different ways. So what are the implications of unclear messages? Well, first of all, the public is confused. We have the same document. My read on the NTP report and their conclusion is that there are concerns about developmental neurotoxicity of fluoride, but others are dismissing the NTP document because the National Academy of Science is saying that they need to be more clear in their process. So now we have a lot of confusion. What does this all mean? So it's critical that science is done in a transparent manner in order to get the buy-in. Without this, regulatory systems are slowed, and the ultimate implication is that this can account to enormous costs at the population level. So I'd like to conclude with just pointing out that my graduate student, Ripka Green, and I wrote this commentary last year in pediatric research describing our experience in doing fluoride research. And lastly, my close collaborator, Dr. Bruce Lanphier, and I produced this video that you can find on Little Things Matter. And this was produced to disseminate our findings to a broader public, in which case we have an obligation to communicate in a way that is not only accurate, but also understandable to ordinary people. And lastly, I'd like to acknowledge my many collaborators and my amazing team at York University, the graduate students, and some postdocs, the support from MIREC, the lab technicians at INSBQ and Indiana University, and of course, the funding sources. So thank you, and I hope to get some questions.
Thank you so much for that thorough presentation. We are now going to start a question and answer series here. We do have limited time, so I will just forewarn, if you have a longer question, we may have to ask it through email and respond to you that way, just because there's some longer ones in the question and answer box. And Claire Gervais and myself will be kind of moderating the questions here for Christine Till to answer. So I will start it off here with kind of a combo of two separate questions. One is, what is the source of fluoride today? You know, is it an industrial waste product, or is it created specifically for water treatment?
Right, so like over 90% of the fluoride that we add to public water supplies is purchased from phosphate fertilizer companies. I know in the city of Toronto, it's bought from Florida. So it's hydrofluorosilicic acid is the name of the compound that we add to our drinking water.
And just the second part of that is kind of, you know, can you boil fluoride out of water, or do carbon filters remove fluoride?
Right, so no, you cannot boil fluoride out of water. Carbon activated filters like a Brita does not remove fluoride either. You need specialized filters like reverse osmosis systems, deionizers with ion exchange resins. So specialized filters are needed. They need to be maintained to work effectively and efficiently.
There's a question, if the presumed level is above 1.5 grams per liter, can you explain a safety or uncertainty factor and level that would be considered safe for vulnerable people or children?
Yeah, I mean, this is what it's really all about. When you think about chemicals and safety, where's the safety factor? So this is where the debate has exploded, because if we have considerable evidence that fluoride is a neurotoxin at 1.5 milligrams per liter, that's only twice, like 0.7. The optimal level is not that low, especially when you think about certain individuals who drink a lot of fluoride, a lot of water and other sources like tea. It's not that hard to double your exposure. There are also genetic like susceptibilities or people with kidney dysfunction that would put them at higher risk. And that's why we have safety factors. So when you look at it that way, this has caused many people to have concern about the optimal level of fluoride, what we could say is safe, because that safety factor doesn't quite match up. We did a benchmark dose analysis, which is meant to identify, this is still in review, but it grouped the MIREC data with the element data to look at what is the minimal concentration to detect a loss of IQ of 1 point. And it is roughly like 0.2 milligrams per liter. So if you're using benchmark dose, then you would have a much lower level as considered, you know, a safer level.
Thank you. We've got a question here about the IQ. So in terms of reduced IQ, what do you think is the reason that boys were more affected than girls?
Yeah, so we've written about this sex-specific effect. There are differences from sex steroid hormones. There's differences in rates of development. There are differences in fetal transport between if you're carrying a female or male fetus. So we don't know for sure why males might be more susceptible, but we do know that when we look at the learning disability literature, ADHD, autism, males do have a higher risk for neurodevelopmental disorders. Why is that? So we're actually doing a larger systematic review looking at whether this pattern is also found with other neurotoxicants. Are males more susceptible to prenatal exposures? So this is an area of current research. I don't have the answer why males are, but it's not overly surprising. And even when we started this research, when we started writing the grant, this was a question of interest of ours from the very beginning.
See, I'm going to combine a couple questions. There's a question about if there's a risk of adverse neurotoxic effects with increased levels of fluoride, drinking water fluoride concentrations. I think the answer is probably yes to that, but I'll let you answer that. And then should there be warnings about preparing infant formula with fluoridated tap water? And is there more evidence that those warnings are needed in areas where where there is high water fluoride levels?
Yeah, okay, so I think that there's lots of questions in there. The very first question was, is there evidence of adverse effects of water fluoride? Was that the first question?
Yeah.
Yeah, okay, so I do want to make it clear that our conclusion, if you noted, the wording was very careful. It said we recommend reduction of fluoride intake in pregnancy. So that's very different from saying, don't drink water, don't drink fluoridated water, because fluoride can come from other sources as well. And when we're measuring fluoride in urine, we're measuring all the sources of fluoride. Now, if you connect the dots, you'll say, well, what is the main source of fluoride? And the main source happens to be drinking water. So we know that fluoride from the drinking water accounts for about 50% of what we're measuring in the urine. But there's variability. You could live in a non-fluoridated community and drink tons and tons of black tea and have high urinary fluoride. So the recommendation that we have is, regardless of where your fluoride comes from, you might, if you're pregnant, think about reducing fluoride intake from all sources. By the way, the fluoride from drinking water is the main source if you live in a fluoridated community. So that's recommendation one. In terms of infants, now this risk-benefit analysis is a bit more clear, if you ask me, because there are no benefits of fluoride until the teeth erupt. So from 0 to 6 months, and we certainly do not prescribe fluoride supplements to the pregnant woman. That has been shown with RCTs to have no benefit. So it used to be thought in the 80s that it would strengthen enamel, but that has been disproven. We have evolved our thinking, and doctors do not prescribe fluoride supplements to pregnant women. So from 0 to 6 months, now we have the formula question. Should we be giving fluoridated water? The answer is there's no benefit, but there's potential for harm. Okay, so the verdict is out there. It increases risk of enamel fluorosis. That's been shown multiple times. We have one study on IQ. So we can say there's potential risk. There's no benefit, but potential risk. So should we be labeling, telling? I think it's important for women to be informed. I certainly do not think we should be selling, marketing fluoridated nursery water when there's no benefit. That makes no sense. But at this point, I think advising women that this is what we know so far, you may want to make an informed decision. The question then becomes more complicated of, well, what type of water should I use? And we're also not advocating like going out and buying bottled water, but that is an option.
I'm going to combine a few questions here. Do you think that this is an environmental justice issue? And someone else had commented too about the costs of, water filtration and bottled water. What is the combination of effects with fluoride alongside other neurotoxics like lead and on IQ, and how that relates to environmental justice?
Yeah, I mean, it's an interesting lens because, what we really have are two public health groups against each other. You've got dentists who care about the teeth. That's their job. Teeth are important. So, this group, they're not adding fluoride. It's not like lead and chemicals that aren't benefiting people. So there are public health physicians who are trying to improve quality of life for individuals. So that the argument goes like fluoride benefits the entire population, especially those who might have limited access to resources or access to oral hygiene and dental care. So on one hand, you could argue that, if you have a savings of one tooth, at a population level, okay, like some people think that's really the most important outcome. And others, I'm a neuropsychologist. I study the brain. I know the importance of IQ, of behavior in children, and how difficult it is to kind of change neurodevelopmental outcomes. And I look at, the risk benefit. We have some alternatives to oral health, like toothpaste, and looking at what other countries have done to improve dental care. It's super important, but maybe we need to look at other strategies in addition, like not only community water fluoridation is one of many strategies that have been used worldwide. So I think when it comes to environmental justice, we need to understand why it's added, what is the benefit, and how does that relate to potential risk.
Yeah, and along those lines, I don't know if you can comment on these two questions, but there was one about, is there another way to prevent dental caries in children other than community fluoridation? And is there a difference, there's somebody else asked, is there a difference between the fluoride in municipal water and that in dental applications?
Well, okay, we can't end this talk without bringing in sugar. So, and I think we'll all agree that if you want to reduce caries, we need to do something about sugar consumption. So number one, prevention of caries to begin with, right? That like if we didn't have this epidemic of high sugar consumption, we wouldn't be talking about this. So number one is we need to educate and really talk about sugar intake. I think the sugar industry is getting off the hook too easily with the solution that we have alternate means. Other preventative strategies that have been used, I mean, some countries do more education in oral health. Countries like Scotland, for example, have preventative care systems for children, and I believe for people under the age of 18. But they teach young children in school and they have it supervised by the teacher, brushing their teeth. It's a very proactive program for fluoride varnish applications in nursery and primary schools. So there are other ways to also address the high risk individuals who might not have access to proper oral dental care. So I think that's just giving you a flavor of some alternatives that we have.
I've got one that's kind of more talking about, your study that you actually conducted. Can you address or comment on one of the concerns of your study that the children's IQ tests were performed on ages 3 or 4 with no specific on what exact ages they were?
Oh, I'm sorry, ages 3 to 4. So the average could have been, I think it was about 3.5 years of age. So the children were between ages 3 and 4, 36 to 48 months to give the WIPC. Is that the question?
Yeah, they were just concerned because there could be IQ differences between a 3-year-old versus a 4-year-old.
Okay, and just to know how these tests are designed. So we use normed values, meaning a 3-year-old boy is compared to a 3-year-old child in Canada. So your kid's test result is compared to 1,000 other boys of the same age, and they're in like very small increments. So if you're 3 years, 2 months, you're compared to another child who's 3 years, 2 months, because of course there are developmental differences between a 3-year-old and a 4-year-old, but they are relative to other 3-year-olds when we come up with our standardized score.
I'm going to combine a few questions here. One person asks if there's an agreement on mode of action, any suggestion of threshold. And then another person asks, is fluoride mobilized from the bone in the pregnant woman? I just combine those because they seem like pathophysiology.
Oh, yeah, that's a good question. So mechanism, I believe you're talking about neurotoxicity, not mechanism of how it works on the tooth. Mechanism.
That's what I was assuming the question was.
Neurotoxicity, probably.
Yeah, the person doesn't.
Okay. Well, I'll answer for neurotoxicity. I'm not going to go into remineralization and demineralization processes, but that's more of a dental question. So there are a number of mechanisms proposed when it comes to fluoride neurotoxicity. We know from the animal fluoride treated studies that there are anatomical changes and biochemical changes. To name some, there are changes in oxidative stress, changes in acetylcholinesterase, changes in mitochondria function, inflammation, glial activation. Anatomically, we see changes in some hippocampal regions. And so that's just to give you kind of a basic view of some of the mechanisms that have been proposed, what we're currently investigating. So what most of my time is spent doing these days is looking at thyroid function. So fluoride, it's been known for a long time, like even in the 1920s, if a woman was hyperthyroid, too much thyroid, you could be prescribed some fluoride to suppress thyroid function. So we've known for a long time that fluoride works effectively in suppressing thyroid function. So we are testing the hypothesis that in pregnancy, women who have higher levels of fluoride exposure are more likely to have abnormalities to their thyroid functioning. And in particular, women who are iodine deficient. And kind of to our shock, we are seeing that there is quite a high prevalence of iodine deficiency in the Canadian cohort. So that's the first piece to understand. Is there an association between fluoride exposure and higher prevalence of hypothyroidism, especially in iodine deficient women? And then secondly, does that explain, is that a potential mediator? Does disruption to thyroid function account for the IQ differences that we see? So that's what we're currently testing. We're just waiting for the final thyroid hormones to come from the lab, but we've been looking at TSH and T4 and iodine. So this is my leading mechanism that I'm looking at, but it's quite complicated, to be honest. So anyone who says they know the mechanism of fluoride, it's very complicated.
I've got a question that's kind of talking about your work with the formula-fed babies. So one question for the fluoride versus unfluorinated water exposure for formula-fed babies is, were you able to control for the use of filters, even if the water source was fluorinated water, such as a municipal water source? Or was the fluorination numbers based only on what the municipal water source supplied?
Yeah, that's a great question. So one of the limitations of MUREC was it was not designed originally to look at fluoride or type of water used in formula. So we had to do the best with the data that we had collected. The woman completed tons and tons of questionnaires. So we have a lot of information about like occupational exposures and you name it. But when it came to water, and so we didn't have things like type of formula. We didn't know if the woman was giving soy-based or milk-based. So that's a limitation. And we talk about this in our paper, that without that level of detail, soy has higher levels of fluoride than milk-based formula. Different brands can vary. So without imprecise timing, when exactly did formula feeding begin? So we didn't have all the data to estimate our infant fluoride intake value perfectly. In terms of whether the woman had a water filter, that would have been captured in the original paper that we did with the pregnancy. So a woman who had a filter, that would have been recorded, and we wouldn't use the water fluoride concentration. But again, it depends on what type of filter. So we use the data that we had, and we presume that if a mother is drinking filtered water, then the baby's probably having the same type of water. But these are assumptions that we had to go in with. I am trying to get another study going that has much better data on water information on another birth cohort in the US. So that will allow us to look at whether we can replicate this finding with much more precise data.
Well, thank you for answering all those questions. There's a number of questions I think that are related that you've answered already, and then other longer ones I think are going to be hard to squeeze in the time that remains. Unless, Hannah, do you have other questions that popped out at you too?
Yeah, yep. Our goal was to end at 8:10 for everyone that's on, because actually our original goal is always to end at 8, but we always seem to go to 8:10. So there is quite a few questions. So what we have done is our intern Marina has copied and put them all into another document to see if we can get some answers to some of those. And because there is so many still left. Let's see, Claire, maybe we pick out one each. To kind of wrap up here. Just give me a second to scroll through them all.
I'll ask, there's a question just popped in about, do you see a cumulative impact with other metals such as mercury or lead? Is there any work in that area?
Yeah, looking for like synergistic effects. So we didn't do the analysis as like looking at chemical mixtures. So, I mean, this could be done. And we hope others will include fluoride when they do these chemical mixtures studies. The way we included lead and mercury was through our sensitivity analyses, where we would control for lead, and we found that the result remains. I would be curious to see if when you do a study on lead and control for fluoride, what happens then.
All right, I've got a question here. So it's kind of more specific. Can you comment on the NTP study on the animal model published in 2018 that found no IQ effect or organ effects from water at 0, 10, or 20 parts per million? I'm not sure if that person just wants a kind of idea of what you thought of that.
Yeah, okay, so that is a study that was done by the National Toxicology Program. That they also looked at sex effects in that study, and the main findings were not showing behavioral outcomes, changes in their outcome was learning and memory, and the effects were mainly null for the developmental exposures, but if there were any effects, they were in the adults dose. So exposures in the adult rats, not in the developmental rats. I mean, okay, so it's a good group doing the study. It has been critiqued for a number of like the species they used, we can go into the nitty gritty. This is why we don't base a decision on one study. Every study has some methodologic limitations or questions of, why did they use that species when it's been shown to not be as sensitive to fluoride than the typical Sprague-Dawley species that is typically used. So, there's some question marks that remain when I read that study, but just to clarify, there were some associations in learning and memory in the adult rats, if I recall correctly. Yeah.
So much. Yeah, we're over our time. We're at 8:12. But I do want to give Christine, I just want to give you one more chance before I wrap it up. Do you have any other last comments or anything else you want to share?
Thank you so much for allowing me this time to present the research that we've been doing and share our story. I would be happy to answer questions by email if there are any more. And I wish you all the best in Wisconsin, because I know this is a hot topic, and I'm glad to hear that people are interested in hearing about the science behind it. So thank you for coming out at this hour too. And now it's late in the evening. So thank you again.
Yeah. Thank you all who attended tonight. You can figure out how to get more information about the Wisconsin Environmental Health Network on our website and our other events that are coming up. Our website is wehnonline.org, so wehnonline.org. We've got information there, our events, how to get involved, different things there. And I just want to give a shout out too. We've got one more lecture in our four-part series. Have Dr. Leo Trisande who's going to be speaking on March 25th at 7 p.m. Central about endocrine disrupting chemicals. So that's our last lecture of the series. And just want to thank you all for joining us, and please join us for Leo's talk. And thank you, Chris.